related to medicine. So I'm going to try and have a mix of layman's descriptions and more complex descriptions here as we go along. So instead of a picture of Ironbridge, I should probably have had a picture of a half-eaten haggis, given the time of year, but I couldn't find one. But what we're going to talk about today is how we look inside people when they're ill. My official title is Emeritus Professor of Clinical MRI, which is quite a mouthful. It's a sort of fancy way of saying I've retired. I've sort of formally retired last year. What was my job? Well, I was a clinical radiologist for the NHS, a consultant radiologist at Addenbrooke's for 50% of my time. And the other 50% of my time, I researched as an academic into magnetic resonance imaging. So today, I'm going to briefly just mention what's a radiologist, because lots of people say, sorry, what do you do? And there's a difference between a radiologist and a radiographer, which I'll briefly put on the screen. Radiologists basically select and interpret the imaging. Sometimes they do the imaging as well, like ultrasound. And radiographers in general take the images, and that's their main job. The other main difference is that radiologists are qualified doctors, radiographers are not, but the boundaries are blurring. And actually we have some very good specialist radiographers who, for example, will do ultrasound and will report plain X-rays. So it's a bit more blurred than it sounds, but there's plenty of training and that still exists. So I want you to imagine that you're traveling home, that's assuming you've been allowed out, and you have a bad crash and you're unconscious and you get taken to a hospital. So how do the doctors know what's actually wrong with you? They can't really ask you much in the way of questions. They'll obviously examine you, they'll check your blood pressure and pulse and all that sort of thing, and stop any obvious external bleeding. Then they're going to arrange some investigations, and that's a little bit about what we're going to talk about. But if you jump back in time, which is quite useful, if we go back to 1850 or so, when you reach the hospital, there weren't many tests. And what they would do is if they thought you weren't very well and something was going on inside you, you'd get surgery, you'd be opened up. This would mean an anesthetic, a major procedure, an operation. And of course, in those days, there were very primitive anesthetics, no antibiotics, not really much in the way of blood transfusion. So your chances of survival were not very high. This is a wonderfully posed picture from the Mayo Clinic, and the Mayo brothers actually pioneered a lot of early surgery. You can tell it's posed because there's not a drop of blood in sight and it's all wonderfully white. This all changed in about 1895 with the discovery of X-rays with William Röntgen. You'll be familiar with that. This isn't the original picture of his wife's hand, which was the first X-ray, almost formed by accident, but it gives you an idea of what was available at the time. X-rays caught on very quickly, and particularly because of World War I. There were already mobile X-ray units on both sides in the First World War, and they were incredibly useful because, of course, metal stood out on X-rays, as many fractures were also obvious on X-rays. And today we still do a lot of X-rays. Here's some examples. These are modern X-rays, but they're examples of the sort of thing you might have seen in that era. On the left is a patient with TB. So for those not familiar, these are the collarbones at the top. This is the heart here. The black areas are the lungs. And down here below the diaphragm, though you can't really see it, is the liver, and over here the stomach. And in the top corner here, which is all white, this abnormal area is actually fibrosis caused by tuberculosis. On the other side is a picture of somebody who's not taken a very good breath in, and that's because below the diaphragm, this thin white line on the right, there is free air. And this patient has perforated something inside the abdomen. This is a surgical emergency, and he goes straight off the operating theatre. So if you had a crash and an X-ray like this, you would get an operation. X-rays, though, have some limitations because they can only discriminate really 4 things. And if you look at this sideways view of a knee, what you see is the bone, that's the easy bit. Then you see soft tissues, but they all look gray. You can sometimes pick up fat because fat is more translucent to X-rays and it's often darker in color. And of course, gas is black because the X-rays go straight through it. But we don't see any cartilage, we don't see any ligaments, we don't see any tendons, we can't see the muscles clearly, and we'll come back to that in a moment. The other thing about X-rays, of course, is they are potentially harmful, although the risks these days from the very low dose ionizing radiation we use, the risks are really very small. Over the years, people exploited all sorts of different things to try and get more out of X-rays. And some of you, I'm sure, will have undergone the pleasures of a barium enema, which is on the left. So by putting in a material which is dense to X-rays and comes out white on this particular view, you could run this material round the colon. You actually have to tilt the patient and roll them round to get it over here to see the right side of the colon, that's the cecum, in order to take then pictures to see if you could find a polyp or a tumor or something similar. On the right side of the screen, by putting a small catheter, a fine tube in the artery in the groin, you can push it up into the main blood vessel of the body, the aorta. This is a subtraction film. You can just see the vertebral bodies at the back. And this is a view of the spleen. So by selectively getting the catheter tip into the splenic artery, you could outline the spleen and show all the vessels, and also see if it was leaking somewhere, if there was a bleed. And over the years, just about every possible part of the body, someone somewhere in Europe or the world devised a technique for sticking a needle into it and squirting something in to try and demonstrate it. And largely that worked quite well for the below the neck part of the body, although some of these tests were fairly unpleasant, I have to say. But the problem was the head, because the skull is a bony structure and you couldn't see anything of the brain on an X-ray. Many of you will remember Desmond Hawkins. This is actually a picture of Desmond lying horizontally in this weird machine. And Desmond was demonstrating the positioning for an air encephalogram. This was a procedure used by the neuroradiologists, and he was an expert at it. What you do is you do a spinal tap, you take out some of the fluid around the spinal cord and the brain, and you'd replace it with gas or air. And then by manipulating the patient, this chair he's in swivels in all sorts of different directions. You can see he's strapped in. You could manipulate the gas up into the head and then take pictures of the gas itself, which would stand out, and see if things were being displaced or moved around. Frankly, it was a fairly crude technique. It involved a general anesthetic. Patients came away with a massive headache and often had to stay in hospital for a couple of days. But here's an example. There's air in the ventricles of the brain here. You wouldn't normally see this. And the air in the ventricles are displaced over to this side of the head. This is a frontal view. The orbits are down here. And it means there's a mass somewhere in this side of the head. And that's about as good as it gets. So if we get to 1970, for example, within living memory for many of you, I imagine, and you're in a car crash and you get taken to hospital, what's going to happen? Well, actually, you might meet Roy Kahn and you'll still get an exploratory laparotomy, because there still wasn't much in the way of sorting things out if you came in acutely unwell and deteriorating. And you can see this is one of Roy's artworks. He's labeled it the moment of truth, when you actually open the abdomen and find out what's really going on. So amazingly, that was still the situation in the 70s. And when they looked inside to find out what trauma there was, they'd quite often take out a few other organs that were felt to be irrelevant. I'm perhaps overdoing it there, perhaps not as useful to you as you might think. So they might take out the appendix, the gallbladder, and often the spleen went too, though they subsequently realized the spleen was quite important. So nowadays we preserve the spleen, we don't whip it out. Things changed in the 60s and people started to be able to see inside the body with ultrasound. And the two people that pioneered this in the UK were Ian Donald and Tom Brown in Glasgow. Ian Donald was an obstetrician and Tom Brown a physicist, and they pioneered the use of ultrasound in maternity. And again, some of you might remember these huge gantry machines, very cumbersome, which were used for static ultrasound pictures. Here's an example on the right. This is actually not a static one, but it shows a baby's hand. The black stuff is fluid. Here's the nose, the mouth, you can just see here. and the skull is the structure in the bottom right. This made quite a difference, but again, even in emergency situations, there wasn't really time to put a patient through this sort of procedure, so you're still going to get surgery. This was until really the early and mid-70s when computed tomography was invented. So Godfrey Hounsfield and Alan Cormack both won the Nobel Prize for this in 1979. And the first pictures were really very crude, but here you can see, if you remember the gas I showed you in the air encephalogram, you can see the same structures here, the ventricles. This is an axial, a cross-section through the head, front here, right, left, and the back of the head. Even though these were rather low resolution, it revolutionized essentially neuroradiology. Air encephalography died overnight, that procedure that Desmond was doing. And here's Desmond again, looking a bit more like he usually did, teaching medical students. And this is the first head CT scanner in Addenbrooke's in 1975. Addenbrooke's was lucky to get one of the first in the UK. And Desmond actually became quite unpopular with his colleagues because he insisted they send a diagram of the brain with where they thought the lesion was. Then he'd do the CT scan and tell them where the lesion really was. And of course, that caused a bit of unhappiness for a while. And I think he gave it up after a few months. But this was really a huge shift in what you could do. This is a modern CT. It shows a mass here, high up in the head, displacing a structure across the midline. You wouldn't see this on an old air encephalogram. It would be impossible to visualize. So this made an absolutely huge difference to seeing inside people's heads. But CT was also useful in the abdomen as well. Again, you see fat, dark line. Here's subcutaneous fat at the front. See the bones. The soft tissue, though, is all gray. The aorta here with blood in it is also gray. So there's not much discrimination. We'd quite often put some iodine type substance into the gut to make it bright so you could tell where the gut was. And initially, although it gave you a lot of information about what was going on, there were some limitations. These could be overcome by having an injection in the arm. And again, if you've had a CT, you may have experienced the injection in the arm, which sometimes gives you a warm flush. And the reason for that is because it dilated the blood vessels, but also different tissues had different blood supplies. So actually this structure here, which looks on the left like the liver, is actually a benign lesion in the liver and expanding it. You can see the spleen looks slightly different on this study as well. So there were ways of extending the role of CT. And then in '85, this is really about the time I started training in radiology, MRI became available as a clinical tool. And the first MR picture was this one on the left. It's a picture of two test tubes of water. And this was taken in a laboratory by a guy called Paul Lauterbur. And subsequently, Sir Peter Mansfield also developed a similar technique, and colleagues in Aberdeen in this incredibly bizarre looking structure. This is a prototype MR scanner, 1979. These two won the Nobel Prize. And a third player, Damadian, produced one of the first pictures of the human body through the chest. The Nobel Prize for this was awarded in 2009, partly because it only went to the two on the left, and the guy on the right, Damadian, complained and published full-page adverts in the New York Times saying he'd been ignored. He was a quite frankly objectionable individual, which probably didn't help his cause at all. So the benefits of MR are the lack of ionizing radiation, a wide range of soft tissue contrast, and the fact that it uses a magnetic field and radio frequency. But in the early days, it was quite slow. So if people moved, particularly in the abdominal world, you got blurry pictures. So we didn't really use it much in the abdomen in the beginning. It was used on the head and on your limbs where you can keep nice and still. Another problem would be if you'd had a ferromagnetic clip left behind from surgery previously, it created a black hole. And here there's just a big black hole instead of seeing the edge of the vertebral body and the muscle here. You could sometimes get a black hole that completely removed half the picture. And of course, there were some potential hazards if you had these clips in your brain that they might be loosened. So there were some hazards related to the magnetic field. The machines were also expensive, quite difficult to install. We had to knock the walls out quite often to get them in. And sometimes people did stupid things. So here's an emergency resus trolley stuck to the magnet because someone has foolishly taken in a ferromagnetic object. So as I say, there were some hazards. This is, of course, carefully protected against these days with all sorts of checks. So if we go back to that X-ray of the knee with its limited contrast, which I showed you earlier, and then we look at an MR of the knee, you can see you get the bones. This is just a thin slice through the middle of the knee, so we don't see the whole of the bone. This is the femur, this is the patella. You see the quadriceps tendon, the muscle in the thigh, the patella tendon down here, which you can damage sometimes. The cruciate ligament, this is one of them at the back of the knee, the sort of thing that footballers manage to break. In fact, these days, if a footballer is bought by a club, they get sent for an MR of the knee to check what's going on and to make sure it's intact. And in this patient, this little eyebrow feature here in the middle is actually a displaced meniscal tear, which was causing the knee to lock when they flexed, bent the knee. You can also see some fluid here, and you can see the cartilage. This is quite an old study. This is from the late 90s, and the studies we get now are of even better resolution than this one. But it shows you the idea. You see the muscles, you see the fat, you just see a whole lot more in terms of the soft tissue detail. Here's another example. This is a neck. You can see the vertebral bodies on the X-ray. The X-ray, of course, picks out the air. So the air at the back of your throat, where you're having your COVID test, will be somewhere up here. The airway comes right down here, and then down here at the front, the trachea. You can see the teeth and the jaw. It's a sideways view. In this space here is the spinal cord, but you can't see it. But with an MR, you can see it, and you can see it in remarkable detail. So here's the spinal cord. On this particular arrangement, T1 imaging, you see the fluid as black. On this T2, you see the fluid as bright. But you also see the cerebellum, the midbrain, and the brainstem. In a way, you just don't see anything on a plain film. This is actually my neck from 10 years ago. I have a nasty feeling it won't look quite as good as this now. We'll see. So in the intervening sort of 15 or 20 years after those inventions, things were improved in terms of resolution and speed. But perhaps the biggest transition was to digital systems. And now, instead of having this huge film library in the basement of Addenbrooke's, with many of these packets, each one for a patient, and all labeled with different colors for the patient's codes and types of examinations, plus a huge number of staff managing all this, that's all gone, completely replaced by computers and workstations with screens and an enormous data store. There are two, they're split between two different buildings so that if one floats away or falls down, we still have all the information in another one. So this made a big difference, and it also speeded up the CT and MRI studies that we could do. So since then, the last decade, we've seen a move from straight anatomical imaging towards more functional imaging. So CT scanners work by having an X-ray source that spins round. The body, the pink bit in the middle, is exposed to the X-rays, and you have a set of detectors on the far side that detect what X-rays get through. And it's the amount the X-rays are blocked is what dictates the picture that you get in the end. And then there's a clever mathematical reconstruction, actually based originally on 3D crystallography work at places like the LMB, to reconstruct the image using originally back projection techniques. But more recently, we're starting to see more use of injected radioisotopes. So these aren't transmission agents. You inject something into the bloodstream, it moves around the body and collects in different places, and then it emits radiation of different forms. Positron emission tomography is perhaps the most widely understood, and that uses or effectively generates gamma rays which hit the detectors, and from these you can create a picture. It's not a detailed anatomical picture, but it tells you what's going on in terms of metabolism. And there's a fashion for sticking the machines together. So a CT and a PET scanner, or an MR and a PET scanner, so you combine anatomy and function. And is that useful? Well, of course, yes. Here's a CT section through the pelvis at the level of the blue line here. And you can see most of the tissues are a rather gray color. And so you can't really discriminate muscle from bits of bowel. Some of the bowel is lit up with the white material that makes it obvious, but not all of it. There may be lymph nodes, they'll look gray, there may be tumor. And a matching section in the emission scanner shows that there's a lot of activity here. And most frequently used as a glucose agent, and many tumors munch glucose much faster than ordinary tissues, which is why they stand out. So if you stick these two together, you get a combined picture. And this tells you you can go back and find out exactly where the lesion is. And if you need to do a biopsy, you know exactly where to go when you're using the CT machine, because you can't really do a biopsy in a PET system. So if we move forwards to 2021, where are we now in terms of the imaging that we do? Well, the invasive methods of the last century, many of which were a little barbaric, are mainly used for therapeutic treatments, for treating people, not for diagnosis. And largely we've tried to use non-invasive methods wherever we can to make the diagnosis and save the invasive methods for treatment. The imaging here in the UK is always targeted to a clinical question. You may think that's obvious. And of course, the key question is, if we're going to do a CT scan or an MR scan, is it going to make a difference to someone? And that means, is it going to help with the diagnosis, the treatment, or the prognosis? Not just because you fancy a CT scan. You may think that's a funny thing to say, but I think in some areas of the world, it isn't running quite the same way. So currently X-rays are still very widely used, and every radiologist in the department, when I started there were 12, there are now 50. Everyone does a session of 2 hours reporting plain films during the week. And I bet today they've done about 5 or 6 of these pelvic X-rays, given the weather. And on the right, you can see the hip and the nice outline of the head of the hip in its socket in the pelvis. And you can see a nice line down here to the femur. But if we look on the other side, you can see those lines are disrupted here and it's shortened. And that's a fracture of the neck of the left femur, which was impacted. So the head's still intact. There's a whole range of different types of fracture you can get. So this is an impacted left neck of femur fracture. So other forms of X-rays, all that catheter stuff I showed you earlier on. This is one of my colleagues, Dr. Winterbottom, and he's catheterized a patient in the groin here. The patient's all covered up with green cloths to keep everything sterile. The patient's awake during these procedures. He treats patients really to unblock blood vessels. And these days that could be almost anywhere in the body. So legs, brain, for a stroke, for example, they'll try and unblock a stroke blocked vessel. If they're in the lungs, pulmonary emboli, you can try and suck out the blood clots from the pulmonary arteries. And in the heart, you can obviously stent people, though the cardiologists do most of that themselves. They can also stop internal bleeding or drain blocked organs. And again, the importance of that, it can be done interventionally in a way that doesn't involve surgery. So by using the guidance of the imaging systems, you can find your way to the right place. And this avoids an anesthetic and all the trials and tribulations of an open operation and the scar and wound afterwards. So ultrasound in the current era has really exploded into all sorts of different flavors and is very widespread. Even I'm amused, in sports medicine, there are lots of portable ultrasound systems used. Say in the Tour de France, the team back at the hotel will have a whole range of ultrasound systems to look for muscle tears and things. Here's an example looking into the liver. What we're looking at is partly 2 vessels run close to each other in the liver, hepatic artery and a portal vein. And you can work out which is which. I hope this works on the Zoom, we'll see. You can work out which is which by listening to the flow profile, which is what's on the left screen. And so I find the vessel on the right, the hepatic artery, freeze it, and then we listen on the left screen, and you can see it's an arterial waveform. So you can use this to work out, first of all, what type of vessel it is, but also to check the vessels are patent. So I used to do this a great deal for liver transplant work, where we check for the first week that the patient's hepatic artery and portal vein remained patent. And occasionally they blocked and had to go back to theatre. Another example, I'm sure you'll all work out what this is fairly quickly. This is a 4-chamber view of the heart. So ventricle, ventricle, atrium, atrium. So these 2 chambers on the left pump blood through into the main muscle chambers, which pump the blood around the heart. And you can see, I'll just run it back briefly. You can see the valves flipping. These are the tricuspid and mitral valves that sometimes go wrong and need replacing. So ultrasound, very good at demonstrating cardiac function. What about CT? So was CT replaced by MR? Well, no, it hasn't been. What's been fascinating really has been the development of all sorts of other things to speed CT up. So back in the 70s, a head scan might take 10 minutes to produce 10 slices, typically about 10 to 15 millimeters thick, often with a gap in between the slices. When we used to do body scans, I remember I used to do this with Adrian Dixon, who set up the first body CT scanner at Addenbrooke's. We'd get 30 slices from a patient through the abdomen, and it would take 30 minutes. And we spent ages discussing this because the scanner had to cool down after that. So you can imagine a patient might take 45 minutes to get through the single scanner we had. And that's why they were called cancer scanners, because we didn't really have the ability to put other things through them. They were really dominated by the diagnosis and treatment of cancer. That's not the case now. So in 2021, we can take a whole body CT scan in 15 seconds, going from the head to the feet, and that can generate 1,500 images. So I'll show you, this is actually, I've jumped some of the images here, and it doesn't include the head, but it gives you an idea of just what it's like, I hope, if it transmits all right on the system. So this is running through the chest. You can see the arms on the side here. We're just hitting the diaphragm, stomach with an air fluid level. That's air in the black area. This is a trauma patient who's come in and come off the East Anglian Air Ambulance. And what they do is they stabilize them, and very quickly they put them into the CT scanner and run the CT scanner through, then take them out again and continue to work on them. And they get a report within a few minutes of what's actually going on inside the patient, and they can make a decision about whether they're going to operate or not. We've reached their hips at this point. There's the patient's hand. Here's some of the equipment sitting on the front. So just ponder for a second that in 15 seconds, you can generate 1,500 images, whereas 40 years ago or 30 years ago, we were looking at 30 images a patient, and it took 45 minutes. So just the productivity and the throughput is tremendously different. We started with 1 CT and 1 MR in 1985. By the time I left, we had, in fact, last year, there were 6 CT scanners and 7 MR scanners operating. MRI, so 5 hours in 1977 to get this fairly bizarre picture of the chest. Here's a picture, it's a sort of front-on view of the liver. You can't see the liver, but it's of the bile ducts, which are the white bits, and the bile duct with a stone in, that's the stone sitting in the bile duct where it will cause trouble. This is the gallbladder, this is the duodenum, this is the duct in the pancreas, and here's the stomach. This was obtained in 1 second, just a single breath hold, and there's no injection of anything. The system uses the fluid content to generate the picture. So instead of having an endoscopy, an ERCP, and someone having to pass the endoscope through the stomach round into the duodenum and then put a cannula back into the bile duct, which is what used to happen before, this can be done as a very easy, simple procedure in the MR scanner. And then you can send someone off if you find a stone. Of course, then they do have to have an ERCP to take it out, but at least they didn't have to have one to find it. And I spent a lot of time on these water-based techniques. We pioneered some of the work imaging the small bowel. So this is a section, again, front on, gallbladder up here. There's the pancreatic duct, stomach. This is the small bowel, effectively filled with water, which demonstrates quite nicely the fine folds of your small bowel. So this reaches to the cecum down here and would join with the large bowel, which I showed you earlier on. Then on the right, a fetal image. We don't routinely do fetal MR. We do them sometimes as part of a project and sometimes when there's a specific abnormality because ultrasound usually gives us all the answers. But these images obtained again, each one in a single second. So things have speeded up considerably. So I can sense that some of you will be saying, well, with all these gadgets and things, why am I waiting for a scan? And of course, one of the banes of our lives in the hospital has been that there are always waiting lists. And at the moment with COVID, of course, much of the outpatient activity at Addenbrooke's has been slowed down or stopped. Certainly in the first lockdown, there was a huge stoppage of outpatient activity. So a whole load of outpatient studies were delayed, and they've managed to work back through some of that. But if I put in context for you some figures, on the left, the number of MR scans per 1,000 population, 2018, we're 67, France 120, Germany 149, 148, 92 in Spain. So we do far less actual examinations per head of population. And the job I used to do, radiologists per 100,000 people in Europe, the UK is down here, 7 per 100,000. Why Greece has 31 per 100,000, I have no idea at all. Seems completely mad. But we're way down the bottom of the list in terms of the numbers. And if I have to look at every one of 1,500 images, not quite every 15 seconds, you can see that there's an issue here in terms of manpower. And the other thing just to point out is the number of bits of equipment per million population. These are slightly older figures, but I couldn't find any new ones. It may have improved slightly. But the number of CT scanners per million, we're down here. Again, we're at the bottom of the table, 9.5. The OECD average, 26. Japan, 107, has 10 times as many CT scanners as we do. That just seems crazy. Overkill in terms of what's going on. So that might explain to you, we could get into the percentage of your GDP you use on health, but I don't think there's enough time to do that. But you might now understand why sometimes there's a bit of a waiting list. So I thought I'd finish by just mentioning COVID-19 and show you a couple of examples of, hopefully now you're all being immunized, what you're avoiding. On the top left here is a normal chest X-ray. So the heart, the lungs, nice big lungs, they're nice and dark. You can see the ribs. And if you take a section through the top of the heart here, then the CT scan would look like this. So nice, even looking appearance to the lungs. The little white bits are actually blood vessels here. And these dark tubes are the main airways in and out of the lungs. So if you're unfortunate enough to get COVID and get it badly, things will look like this on the top right. So first of all, there's a tube in the airway. So this patient's on a ventilator. They have a tube into one of the main blood vessels for monitoring and maintaining their fluids. Here's the heart. Not very big lungs because they've not taken a very big inspiration because they can't breathe in properly. And these patchy white areas are all basically infection, consolidation it's called in our terms, infection in the lung. And if you take the same section across here, then you see it's patchy. There's some areas that look good, but there's plenty of areas that don't look good and are not functioning properly as part of the lung. So really that's the problem. You have to get rid of these white areas effectively in order to be able to breathe properly and survive. There are, of course, a whole range of additional complications. COVID-19, for some reason, seems to predispose to blood clots, and these can be in a whole range of places, which have contributed to some of these features of long COVID that you hear about. So I think I'm going to stop there. I hope I haven't horrified you all, and I hope it is vaguely self-explanatory, but I'm happy to answer any questions. And I'll leave you with a picture of little Wilbraham. So thank you.